Hello and welcome to Med4Care. I am Dr. Care and today's topic will be the polyuria. Let's find out together what it is. Polyuria is a disorder of diuresis which consists in the production and emission of urinary volumes above the norm, generally greater than 2,500 to 3,000 milliliters during the day. Polyuria may in some cases depend on purely physiological and homeostatic causes, but often, it recognizes the onset of chronic pathological mechanisms, such as the presence of diabetes mellitus or renal failure. Polyuria must be distinguished from polyuria, since, in the latter condition, what increases is the frequency of urination during the day and does not necessarily also imply an increase in the expelled urinary volume. The body's water homeostasis is strictly controlled according to the amount of water introduced during the day and the volumes of liquids expelled by the body itself, both consciously as in urination or defecation, and involuntarily through perspiration and sensibilis. In particular, the antidiuretic hormone, ADH, also known as arginine vasopressin, exerts its action on the collecting ducts of the renal tubule, stimulating the absorption of water and inhibiting diuresis. This event occurs especially when plasma osmolality increases, like the concentration of solutes in the plasma, for example in conditions of dehydration. In conditions of normal hydration, the osmoreceptors of the central nervous system perceive that the plasma osmolality is at balanced levels, and therefore inhibits, at the level of the hypothalamic nuclei, the release of the antidiuretic hormone ADH. The production and emission of urine are therefore under the balanced control of a ratio that also takes into account the amount of liquids introduced from the outside and the concentration of solutes dissolved in the plasma. In some cases, the emission of higher than average urine volumes over the course of 24 hours is not necessarily attributable to pathological mechanisms, but may depend on the precise homeostatic balance of liquids seen above. In particular, an excessive intake of liquids such as highly hydrated drinks and foods, disproportionate to the body's needs, can induce polyuria, due to the reduction in plasma osmolality which acts by inhibiting the release of ADH. Some substances can exert an irritating activity on the renal tubule, such as caffeine and alcohol, and, in these cases, renal function is stimulated, resulting in polyuria. As can be guessed, we refer, in this case, to the intake of large quantities of caffeine and alcohol, well beyond the interindividual average. Polyuria can also be the natural consequence of a course of drug therapy based on diuretics, such as furosemide, which are aimed precisely at a more conspicuous emission of urine during the day, for example as a therapy against hypertension. Finally, even the so-called potomania, that is a form of psychogenic polydipsia, in which an individual is affected by the uncontrolled disorder of drinking fluids, can inevitably lead to polyuria, with the expulsion of more than 2,500 milliliters of urine during the day. Polyuria manifests itself as a complex disorder of diuresis and must be thoroughly investigated to promptly recognize the mechanism that induced it, thus directing the patient to the most appropriate treatments. Generally, four main mechanisms of polyuria are recognized. Polydipsia, that is the tendency to consume liquids in a large way during the day, is a condition that can be of a benign nature such as in states of dehydration or during sports activities, or it can be attributed as a secondary consequence of some diseases on a chronic basis. The antidiuretic hormone, or ADH, as seen, is a hormone produced by the supraoptic and paraventricular hypothalamic nuclei, and acts at the V2 receptors located in the cells of the renal tubules. The effect of this hormone is to inhibit diuresis, promoting the absorption of water. When a deficit in its secretion is observed, as in central diabetes insipidus, the hormone cannot stop diuresis and as a consequence, polyuria is observed. Diabetes insipidus is not only of a central nature, as seen in the previous case, but can also derive from the fact that the V2 receptors for ADH do not respond optimally to the hormone, thus not signaling to the cell the command to reabsorb the water. This condition is called nephrogenic diabetes insipidus. It may happen that a certain solute reaches, at the level of the interstitium of the tubular cells of the kidney, a concentration so high as to prevent proper reabsorption by the cells, as the concentration totally saturates the receptors aimed at internalizing the solute. This condition is at the basis of most cases of polyuria and is typical of uncontrolled diabetes mellitus. In this case, when the blood glucose concentration exceeds the threshold of 180 mg/dl, the so-called renal glucose threshold is exceeded, the tubules are no longer able to absorb glucose, which will inevitably be found in the urine, glycosuria. However, in addition to glucose, water will also be produced, since the solvent, therefore water, for osmotic reasons, tends to follow the direction of the flow of the solute, then finding itself in the urine and increasing the volume emitted. The correct assessment of polyuria is based on the implementation of the following procedures. The nephrologist specialist doctor and the internist doctor can question the patient, during the medical examination, about all the information they deem necessary for an optimal classification of his condition. In particular, the next pathological anamnesis should focus on asking the patient how long his problem has arisen, how it manifested itself, and what are the volumes of urine emitted during the day. In parallel, any other symptoms, even if of a systemic nature, such as fatigue or fever, should also be investigated. After the anamnestic phase, the doctor proceeds with the physical examination of the patient, inspecting him in full and proceeding to palpate the abdomen and pelvic region, to check for the presence of any masses. This investigation must be integrated with a careful neurological examination, which can be the sign of a neuropathy or an ischemic event, which could be at the basis of polyuria. Before leaving the patient, the doctor usually prescribes other tests for the patient to do to better investigate her condition. These can be laboratory tests such as blood tests, plasma osmolality, and chemical, physical, and microscopic examination of the urine. To better distinguish between one presumed etiological mechanism of polyuria and another, the following provocative tests can be performed. The first is the thirst test. With the thirst test, the patient is totally deprived of the intake of water and other liquids for at least 8 hours. During these hours, if the patient continues to emit urine at normal or increased flows, then the diagnosis of central diabetes insipidus is made, with the inability to concentrate urine. If the disorder is instead of a psychogenic nature, as in potomania, the body will concentrate the urine as ADH works normally. The second is the Desmopressin test. To recognize a state of nephrogenic diabetes insipidus from central diabetes insipidus, the patient is injected with an analog of the hormone ADH, known as Desmopressin. If after 60 minutes from the injection, the patient inhibits the emission of urine and increases its osmolality, then it is central diabetes insipidus. If, on the other hand, the situation remains unchanged, then it is the receptors of the renal tubules that do not respond to the antidiuretic stimulus, and therefore a diagnosis of nephrogenic diabetes insipidus is made. The optimal management of the patient who manifests polyuria depends on the underlying etiological substrate. For example, in the main cause of polyuria, for example, diabetes mellitus, the patient must undergo appropriate therapy, usually based on insulin, biguanides, or drugs incretin-like. In cases of central diabetes insipidus, it is sufficient to replace the deficiency in the production of the hormone ADH with pharmacological analogs such as desmopressin, to induce the same effects of the endogenous hormone. In diabetes insipidus with nephrogenic onset, on the other hand, the correction of the cause is not easily carried out, and often an effective diet is used, which involves the intake of large quantities of water and the restriction of salts. We are now at the end of today's video. We hope you enjoyed it. If you found it useful, please support us with a nice like and subscribe to the channel. See you soon on Med4Care.